All right. So any questions from yesterday?
Nope.
That you got. So like I said, yesterday's review was those are the bones that are going to be on the practical.
Okay.
Okay. I mean, that's how yesterday worked. What I'm going to do today is now I'm going to go over all of these bones and go over the landmarks, the important landmarks that you need to know, because these are the landmarks that will actually be on the daily quizzes. So, and these are the landmarks you're going to need to know when you are palpating another patient, another student, or performing goniometric measurements. So that's what we're going to do today. All right. So with the video that I'm going to send, I'm also going to send the PowerPoint with all of these bones. You're going to see a bunch of PowerPoints from yesterday. But we're really going to go through it and go through the important landmarks that are on them. Okay, so that is what today is about. Let me get to that. And try a different view of this. Can you see this? It says anatomy review.
Yep, I can see it.
All right, fantastic. So what I'm going to do basically is I'm going to go through this whole PowerPoint. It's about 80 slides, but we won't be hitting every single one of them. All right, so I will kind of guide you in what is important in each one. So the skeletal system, what we're doing is we're going over it. Basically, we have the skull, the vertebral column, and that is the that is the basis of the human body. All right, that's what we work off of. And then we have the pectoral girdle and the upper limb, the shoulder and the upper limb, and the pelvic girdle and the lower limb. So what we have is we have an axial skeleton and an appendicular skeleton. Like I said, the axial skeleton is the base. Everything works off of the axial skeleton. So if you look in this on this slide, the axial skeleton is the tan colored bone. So basically the skull, the vertebra, the sternum and ribs, the sacrum, and even that little hyoid bone is part of the axial skeleton. It's what everything is based off of in the human body. The appendicular skeleton is basically your arms and your legs. These parts are colored in green. So like I said, the pectoral girdle, the upper extremity, the pelvic girdle, and the lower extremity. So with these two pictures, you get to see how these bones are all together. All right. So getting an idea of where they're at is really, really important. All right. So knowing how they are separately and knowing how they are together are two really, really important aspects of the human skeleton. There's multiple regions, like I said, the axial and the appendicular skeleton. The axial is the supporting, it supports the body, and the appendicular is basically the arms and the legs. And these are not questions I'm going to ask you on the test. All right, so, I'm not worried about you knowing the axial and the appendicular skeleton, nor will I ask you how many bones we have. We have 206 in the adult skeleton, and at birth, we actually have 300, but what happens is they start to fuse together You know, think of a child's head. We always talk about the child's head having a soft spot. Well, that's what happens. It's soft because those bones in the skull actually start to fuse together. We have certain bones, like I talked about yesterday, that are actually within muscles themselves, and those are known as sesamoid bones. The one that is really known is the patella bone, the patella, which we will be going over, and that is within the quadriceps tendon. What today is going to be about basically is going over most of the bones that we went over yesterday and talking about the surface markings on those bones, because those surface markings are really, really important to physical therapist assistants, because it helps guide us and map us in when we are palpating patients, when we're feeling certain areas. And also we use these landmarks for what we call goniometric measurements when we're taking the range of motion on a patient. So these markings are very, very important. And like I said a little bit earlier, it is these markings that you guys are going to be tested on. The daily tests are where you're going to be assessed with these landmarks. Again, the practical will just be identifying the bone. Like in this picture, we've got a femur, we got a scapula, we've got a humerus, we have the skull. But those three bones, I mean, that's all you will have to tell me. But on the exam, when we talk about the femur, we're going to be talking about the greater trochanter and the lesser trochanter. On the humerus, we're going to talk about the head of the humerus, the greater and lesser tubercle. On the scapula, we're going to be talking a lot about the scapula because there's a lot of surface markings on it, such as the spine of the scapula, the coracoid process, the glenoid fossa, the medial and lateral borders. And all of these markings are really important because all of these markings are actual origins and insertions for muscles also. So they're really, really important. The cranial fossa is basically where the brain is. All right, the brain sits within the cranial fossa. This will be nothing that you will have to know. All right. I basically go through everything and kind of guide things. We're going to be skipping a lot of PowerPoints here. So I'll tell you what's important and what's not. In the cranial fossa, just know that the brain is within the cranial fossa. Yesterday, we spoke about the frontal bone. This will be one of the bones that you will need to know. The only thing that's important to know is the location of the frontal bone. Right? The frontal bone forms the forehead and is part of the roof of the cranium. And it's the bone that is right above the eyes. So if you look right here, here's the thing for the frontal bone, and it's basically this area right here. So if I put a sticker on that area, if I put the number 1, and what you'll write is you'll write the frontal bone, and that will be it. All right. There's really no landmarks that you're going to need to know on the frontal bone itself. Okay. Okay. The parietal bone, again, the second of the skull bones. This bone forms most of the roof and part of the lateral wall. What you're going to need to know about the parietal bone is its location. All right, let me kind of go back here. Thing does not want to work for me. My apologies. Come on. My apologies, guys. Oh, we're just skipping along here. All right. My apologies. Let me kind of go back to parietal bone. All right. So it looks like I'm going to have to stay on this screen. I like that larger screen too. I don't know about you guys. I'm going to try it again. Okay, so again, the parietal bone is the sides. It's on the side of the cranium. It is behind the frontal bone. Again, this bone, all you're going to have to know is the location of this bone. Okay, in this case, the parietal bone is right there, and it's the pink bone right here. This area right here in pink is the parietal bone, split by a suture. There's a right half and a left half. Okay, so if I put a number on there again, let's say I put the number 2, you would just tell me that it is the parietal bone. The next bone don't want to move. The next one is the temporal bone. Now, the temporal bone does have some landmarks that you're going to need to know. All right, the temporal bone, it's located on the lateral side. Hang on it. Will it stop skipping? Why can't I get my pencil? Okay. Okay. So the temporal bone is this area right here in the purple. All right. The temporal bone has a lot of landmarks on it. Okay. The first landmark that you're going to need to know is the external auditory meatus. Now, the external auditory meatus is this area right here that I am pointing to with this arrow. And it is basically the whole of the ear. All right. Of course, we have to have a special name for it because it's the human body. So the ear hole is known as the external auditory meatus, and it is part of the temporal bone. Another part of the temporal bone is the styloid process. I described it yesterday as a needle-like structure. All right, the styloid process is a needle-like structure within the temporal bone. All right, and it's literally right under the external auditory meatus. Another part of the bone that you're going to need to know is the mastoid process. I put a little circle there. It's a small bump behind the styloid process, and it's a bone that is an attachment point for certain bones like the sternocleidomastoid. All right, so the other part of the temporal bone that you're going to need to know is the zygomatic arch. It's basic. The zygomatic arch is basically the cheekbone. If you were to press down on your upper cheek below your eye, you'll feel a bone that actually kind of goes towards the back and towards the ear. That is the zygomatic process. So on the temporal bone, the structures that you're going to need to know is the zygomatic process, the external auditory meatus, the styloid process, and the mastoid process. Right? Those are the parts of the temporal bone that you will need to know. Nothing wants to work for me. Come on, silly. Too much. All right. The occipital bone. All right, we spoke about that yesterday. That's one of the other bones that you're going to need to know. There's really only 2 landmarks that you're going to need to know on the occipital bone. The first one is going to be the foramen magnum. That's that hole on the bottom of the skull, and that is part of the occipital bone. Pretty easy. That is the area that basically holds the spinal cord. The other part that you're going to need to know is the external occipital protuberance. And I described that yesterday as the bump on the back of your head. Now, that area of the occipital bone is where the upper trapezius muscle is its origin. So the upper trapezius, part of the large trapezius muscle, actually starts on the external occipital protuberance. And it's really important that you know that. Okay, so for the occipital bone, the landmarks that you're going to need to know is the foramen magnum and the external occipital protuberance. What you guys will also hear about is these nuchal lines, Nuchal. These are basically cartilage structures that actually allow muscles to attach to those areas. Not something that you're going to need to worry about on one of my exams or even on the national exam. But when you hear about nuchal lines, they're more cartilage areas for muscles to insert into. So again, for the occipital bone, the foramen magnum and the external occipital protuberance are the structures that you're going to need to know. And we're probably going to be skipping through a bunch of bones here. The maxillary bones, you're not going to have to worry about. Like I said, the zygomatic arch, all right, that is part of the temporal bone. Okay, so the zygomatic arch, you're definitely going to need to know. It's the bone, again, in purple, literally right next to the external auditory meatus. So definitely a structure that you're going to need to know. Now, the mandible, like I said yesterday, is really the only moving part of the skull. It is really an incredibly strong bone, and it's the area basically that supports the teeth. Now, you're going to need to know certain parts of the mandible. You're going to need to know the body of the mandible. All right, let me get my pencil out. So the body of the mandible basically goes from here to here. It's basically the largest structure on the mandible itself. You're going to need to know the angle of the mandible. That's this area right here where it starts to turn. The ramus, you will need to know this area here from the angle to the mandibular condyle. The mandibular condyle, there are two of them. These are the parts of the bone that attaches to the skull and makes up the temporomandibular joint, the TMJ. You will need to know the mandibular condyles. In between the mandibular condyles and the coronoid process is this hooked area on both sides. These are the mandibular notches. You will need to know that. And finally, this blunt area right here at the end, those are the coronoid processes of the mandible. You will need to know that. So the structures on the mandible that you will need to know is the body of the mandible, the angle, the ramus, the mandibular condyle, the mandibular notch, and the coronoid process. So those are the areas that you're going to need to know on the mandible itself. right? You will not have to worry about the hyoid bone. And that's the end of the skull portion. Aren't you thankful for that? All right. Why is it skipping through things? Guess it's not. All right. So the next part is the vertebral column. Again, there are 7 cervical, there's 12 thoracic, and there's 5 lumbar. There's also 5 sacrum and 4 coccygeal, and that's what adds up to the 33 vertebra. The job of the vertebra is to support the skull, allows for movement, it protects the spinal cord, and it absorbs a great deal of stress from all of the walking, running, and lifting that we do. So the vertebral column is a real important part and a part of the body that we work on a great deal. Again, this is the makeup of the vertebral column. Like I said, 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 4 coccyx bones. You're not going to have to know this for the test, but just know that newborns basically only demonstrate one curve, one continuous C-shaped curve at birth, and this is known as the primary curve. What happens is as we get older and as we are able to lift our heads up and as we start to walk, we develop other types of curves within the spinal cord itself. The adult spinal cord has a few different curves, and these are what we call normal curves. We have cervical curves, thoracic, lumbar, and pelvic curves. At the thoracic and pelvic area, these are the primary curves. These are the ones that are present at birth. But the cervical and the lumbar curves are what we call secondary curves. These curves occur as we get older, when we're able to start to lift our heads up. When we start to crawl, we start to develop the cervical curvature. And again, these curves are normal. So it's really important when we put babies on their stomach and we put them so that they can crawl, so that they can begin to strengthen their musculature and to start to develop these curves. You know, we don't want babies walking right away. That's not what we want. We want them on their stomach. Tummy time is what we call it. As we get older, we start to walk upright. And when we start walking upright, that develops the lumbar curve. So again, the cervical curve and the lumbar curve are more secondary curves. And those curves occur as we get older, when we're as a baby, when we can lift our heads. And as we get older, when we start walking more and we're upright more, we develop those lumbar curves. Now, we also have the quote unquote abnormal curves. We have those curves that are not normal. And you've probably heard of probably at least one, maybe 2 of these quote unquote abnormal curves. A scoliosis. All right. And these abnormal curves come from diseases, from paralysis, poor posture, congenital defects, and even pregnancy can cause these abnormal curves. So scoliosis is an abnormal lateral curve. These are the most common quote unquote abnormal curves. All right. So what I'm going to want you to know about this is what the curves look like here. So a scoliosis is a curve that occurs laterally. A kyphotic curve, all right? This is a curve usually seen in our older adults, all right, in our elderly. and they usually occur due to osteoporosis, due to the weakening of bones, osteomalacia. All right. It could also occur, with weightlifting in young boys, but a kyphotic curve is basically a hunchback, and it usually occurs in the thoracic region. Okay, so our elderly usually have that hunchback, especially when they're leaning forward. So again, scoliosis is a lateral curve. Kyphosis is a hunchback kind of curve. And then the third abnormal curve is a lordotic curve. This is an exaggerated curve. And you will see this type of curve with pregnant women, with people that are overweight. So the curve is really exaggerated. This is a large curve. If you take a look at the picture, so here is a woman who's pregnant. All the weight is in the front of her body. So it's literally pulling the muscles and causing the back muscles to create this exaggerated lordotic curve. Think of somebody that is overweight, that has the quote unquote beer belly, the large belly in the front. Well, all of that weight in the front is pulling those back muscles and creating this exaggerated curve. Okay, so scoliosis, a lateral curve. Kyphosis or a kyphotic curve is a hunchback. And the lordotic curve is a curve that is very exaggerated, usually seen in overweight or women that are pregnant. So let's go over the general structure of a vertebra. Okay, so we have the body. The body of the vertebra is the most massive area of the vertebra itself. It's this area right here. All right, the body of the vertebra is on the anterior portion of the body, where the spinous process is the posterior portion of the body. The body of the vertebra is the primary area for weight bearing. Right, so a lot of weight bearing occurs within the body because it's thicker. This area right here is the vertebral foramen, and that's where the spinal cord goes through. So imagine all the cervical, thoracic, and lumbar vertebra all together, all right, like in one of those early pictures that we saw here, and the spinal cord goes right through there, goes right through the vertebral foramen. And every vertebra has a vertebral foramen. The next part that I need you to know is known as the vertebral arch. Now, the vertebral arch is made up of two parts. All right, it's made up of a lamina and it's made up of a pedicle. The lamina goes from the spinous process to the transverse process right here. That's this bone right here. The pedicle goes from the body to the transverse process. And this whole area made up of the lamina and the pedicle is known as the vertebral arch. All right, so I need you to know where the pedicle is from the body to the transverse process, and the lamina goes from the transverse process to the spinous process. And those two together make up the vertebral arch. Again, on the posterior side, we have this spinous process right here. And we spoke about those spinous process yesterday, and we're going to talk about them again and those important characteristics. So the spinous process basically projects posteriorly. On the sides, we have these transverse process. All right, they look like wings. All right, they extend out. Okay, so the spinous process extends posteriorly. The transverse processes extend out medial and laterally. Also on the vertebra is this area right here. All right, this area is an articular process. This is where the vertebra basically connect and articulate with each other. All right. And on these processes are these facets, these smooth areas. All right. They're covered in cartilage and allow for movement. And that's what allows us to bend our back and rotate and extend our back, because the way these bones articulate with each other. So these are some of the important structures that you guys are going to need to know about the vertebra itself. In between the vertebra are these intervertebral discs. We're going to talk a little bit about it in a few minutes also. What I need you to know about the intervertebral discs is what it's made of. The first part is the center part. The center part is known as the nucleus pulposus. This is a water-based area, and it's where a lot of the forces go through. And when you hear about a herniated disc, it's the nucleus pulposus that has basically broken through and is creating pain. So the intervertebral disc is made up of a nucleus pulposus, and these rings around the nucleus pulposus, they're known as the annulus fibrosus. These rings protect the nucleus pulposus. So what I need you to know about the intervertebral disc is that it's made up of a center nucleus pulposus and concentric rings known as the annulus fibrosus. Excuse me, needed to drink some. All right. This. Nothing wants to work here. Come on. All right, so this picture we spoke of yesterday. These are the characteristics, again, of each level of vertebra, the cervical, thoracic, and lumbar. Again, very important to know. The bodies, all right? Again, that's the weight-bearing area. And if you think about it, you know, the head is really only about 15 to 20 pounds, not very weight-bearing there. So that's why the cervical body is very small. But as we go down the vertebral column, the body gets thicker. All right, so the cervical body is small. The thoracic body is larger than the cervical, and the lumbar body is larger than both. They are massively shaped. All right, so when you're looking at the vertebra, look at the body. It's going to tell you basically what level of vertebra they are. And I'll never ask what number vertebra. All right, I won't say what, you know, what number vertebra is this? Is this L3, L4, or L5? There's no way for you to know. All right, but you'll need to tell me whether it's a lumbar, thoracic, or cervical vertebra because of these characteristics. The spinous process. Well, the cervical spinous process is usually bifid. There's basically two portions to it. The thoracic spinous process is long and points downward. The lumbar spinous process is very blunt and it projects backwards posteriorly. The transverse processes, those are even different. On the cervical vertebra, the transverse processes have transverse foramen that allow the arteries and veins to go to the brain, to allow for circulation to get to the brain. On the thoracic transverse processes, there are facets that allow for articulation with the ribs. Remember, it's the thoracic vertebra that connect with the ribs. The cervical and lumbar do not. And finally, the transverse process of the lumbar area are actually very, very thin. So these are the important characteristics of the vertebra that you're going to need to know. When the vertebrae are together and they are articulating, they create a notch or a space. And I'm circling the space right here. This space is known as the intervertebral foramen. And this is a real important area. The intervertebral foramen is where the nerves basically come out to go to the arms and the legs. And it's in this area that we can get pinching, or even when the intervertebral discs herniate, it can cause pressure on those nerves. So again, when we have two vertebrae together, excuse me, it creates this intervertebral foramen. This intervertebral foramen is the passageway for spinal nerves that come out of the spinal cord, and these spinal nerves go out to the arms and the legs and innervate those body parts for us to move them. Sometimes these areas, again, this area can get pinched. It can create pain that actually radiates up and down your legs and arms. So we would actually have to perform certain modalities or stretching or exercises to kind of help them alleviate and get that space back. And we will talk about the movements soon on how to get rid of the pain when somebody has a stenosis or a narrowing of the intervertebral foramen. Again, the intervertebral discs, they consist of the nucleus pulposus and the annulus fibrosus. They really are basically shock absorbers between the vertebrae themselves. And again, when you have heard the saying a herniated disc, a ruptured or slipped disc, what that means is that the nucleus pulposus has basically left the center part of the disc and is now causing pressure within the intervertebral foramen on those nerves. And when there's pressure on those nerves, it causes great discomfort, maybe in the buttocks, in the back of the leg. Sometimes you hear it as sciatica. Well, the sciatica, you might have pain going all the way down into your calf. Well, that pain is actually pressure on a nerve. So that's something that we, as physical therapist assistants, help alleviate. We have certain exercises that we can perform that will help a patient with the sciatica issue. So again, the intervertebral foramen is the area where the spinal nerves come out. And the intervertebral discs made up of the nucleus pulposus and the annulus fibrosus. Get rid of my pencil here. Oh, I better go back and clear. Okay. How you doing, John Carlos?
Doing good. How are you?
Okay. Did you get the video, by the way?
Yes, I did. Thank
And
you.
is it working?
Yeah, I saw I had a request for you to like,
And
authorize it. But it's
and
working
nice,
now.
and it's working now?
Yeah, it is.
Yeah, I'm trying to find out what that's all about. So my apologies. All
It's
right.
all good.
Anybody else here? Or is it just you and Karen?
It
Karen
seems
might
like
have
it should.
left.
Yeah.
Karen might have stepped out. She had a meeting. So all right. So right now it's just you, kid. All right. Let me see if I can get this moving again. For some reason it's stuck. Like it freezes. Get rid of this. Try it this way. This way. This way. Nothing is working. Okay. Continuing with the vertebra. Again, we spoke about C1 yesterday, which is the atlas. This is the bone that supports the head. This one has no body. All right. The important thing again is that atlas holds up the head, and it's the bone that allows us to basically move our head in the gesture of yes. All right. The up and down flexion and extension is the job of the atlas other than holding the head up, which is a pretty darn important job. All right. So we have atlas. C2 is axis. One of the important jobs of the axis is it allows us to rotate the head left and right when we're saying the word no, when we're gesturing no. The most important characteristic on the axis bone, or C2, is the odontoid process. All right. Crap. When I don't want it to move, it moves. Is this bone right here, the dens, also known as the odontoid process. There is no other bone in the body, no other vertebra that has the dens, only C2. So if I have that on the table and you're looking at it, man, it doesn't look like any of the other ones, but we got this pointy bone sticking up. That will tell you that it is the axis, or C2. When C1 and C2 are together, there's an actual ligament that actually protects the dens from breaking, because what happens is if somebody, quote unquote, breaks their neck, it's usually the dens that they break. All right. And once that's broken, you're done. You're pretty much gone. All right. So this transverse ligament that you see that is on the atlas bone, and it covers the dens and protects the dens. So this is the articulation between those bones. I'm not going to ask you about that ligament, but just know that there's an important ligament that protects the dens when C1 and C2 are articulated together. So again, the characteristics of the cervical vertebra: they're the smallest and they're the lightest. Their spinous processes are bifid. Their transverse processes have transverse foramen. They have holes in them that allow for the arteries and the veins to go to the brain. The thoracic vertebra and the lumbar vertebra do not have transverse foramen. The cervical vertebra at C7 is known as vertebra prominence. It is a landmark that you can actually palpate and get an idea of where you are at. Okay, So those are some of the important characteristics of the cervical vertebra. The thoracic vertebra, again, there are 12 of them. And they correspond to the ribs, basically, because again, it's the thoracic vertebra that the ribs connect to. All right, the ribs connect to the thoracic vertebra and to the sternum. Now, there are some false ribs and floating ribs. We'll talk about that later. But in general, the ribs attach to the thoracic vertebra. The spinous process of the thoracic vertebra is very prominent. It's pointed, it's angled downwards, and it is long. All right, it is definitely different than the spinous processes of the cervical and the lumbar area. The thoracic body is larger than the cervical, but smaller than the lumbar. Again, it's only the thoracic vertebra that have these costal facets, which is the attachment points for the ribs. All right, so those are some of the characteristics of the thoracic vertebra. The lumbar vertebra, they're really hard to be mistaken. Again, there's only 5 of them. They are very thick. All right, the body is very large. The spinous process is thick and short. Okay, so you really can't miss the lumbar vertebra. The transverse processes, they're actually thin, all right, in comparison to some of the cervical and the thoracic. All right, definitely can't be missed, the lumbar vertebra. The sacrum, like I said yesterday, all you're really going to need to know is what the sacrum is, and there's really only one part of the sacrum that I'm going to need you to understand and know, and that's this area right here. This is S1, so it articulates with the lumbar vertebra, the L5 vertebra, and this is known as the sacral promontory, basically the top of the sacrum. And it's S1 that supports the lumbar area. So on the sacrum, the only thing I need you to know is this S1 area, and that S1 area is known as the sacral promontory. This is what the posterior part of the sacrum looks like. I will not ask you about anything on there. Again, if I put the sacrum in the posterior view, it's actually kind of easy to know that it will be the sacrum. On the bottom of the sacrum, though, is the coccyx bones, those 4 very small vertebrae. All right, that's these bones right down here. And I might put the bone on a table and put an arrow right at those bones, and I would say, what is the name of these bones? And you would say the coccyx. These bones are fractured an awful lot during childhood, and really a lot with the elderly, because they really don't have control when they're sitting. The coccyx is a very important area for muscle attachments for the lower extremity. So the coccyx you will definitely need to know, and that is part of the sacrum. It's separate from the sacrum, but it's on the bottom of it. Okay, things were moving along nicely there. Dare I say anything? Okay. Now, so we're going to talk about the basically the front or the anterior portion of the body. So the thoracic cage is basically a protective area for the lungs and the heart. I'm not going to need you to know about the thoracic cage itself, but what I will need you to know is about the sternum. The sternum is the bone, is this bone right here. I'm going to show another picture of it, but the sternum is this bone right here. And it's the sternum is very, very important in that it leads to the attachment of the pectoral girdle of the shoulder. All right. What happens here is that the clavicle attaches to the sternum and to the scapula. So it's this area here is really, really important. So I'm going to need you to understand the parts of the sternum itself. Okay, so let me come out of here. So there's three parts to the sternum. The first part on the top here, this top portion is known as the manubrium. Top portion is the manubrium. Now, the manubrium has a couple of important parts. The first part is in the middle, there's a jugular notch. And that's where your jugular actually comes through there. And it's at this jugular notch that we get protection. On both sides of the manubrium, there's clavicular notches that the clavicle attaches to these parts of the sternum itself. So on the manubrium, you have the jugular notches, the jugular notch, and the clavicular notches. The next part is the body of the sternum, which is the area where most of the ribs attach to. But in between the manubrium and the body, there's an actual line. There's an actual line on the bone itself. And that line is known as the sternal angle. The sternal angle. So the line between the manubrium and the body is known as the sternal angle. The third part of the sternum is on the bottom, and that's the xiphoid process. This is an important attachment point, especially for the diaphragm, the muscle that actually helps us breathe. So again, these are the three parts of the sternum that you're going to need to know. I'm going to actually go back a notch, hopefully. So again, the manubrium has the jugular notch. That's the medial notch. And then on both sides of the manubrium, it has the clavicular notch. In between the manubrium and the body is the sternal angle, which is where the body and the manubrium join. The body is the longest part of the sternum, and that's where most of the ribs are attached. And finally, on the bottom is the xiphoid process, which is the inferior end of the sternum. It's here where a lot of the abdominal muscles attach, and the diaphragm, which is one of the key muscles of our breathing. Now, like I said, it's at the sternum where these ribs are attached. Now, I will put a rib on your practical. You'll have to tell me it's a rib. When we're talking about the exam, I can question you about the three different types of ribs. All right. I'm not talking about barbecued and stuff like that, even though I wouldn't mind. We have true ribs, we have false ribs, and we have floating ribs. The true ribs are ribs 1 through 7. And these first 7 ribs attach directly to the sternum. directly to the sternum. That's why they're called true ribs. We have 3 false ribs. False ribs are 8 through 10. If you look at the bottom of this picture here, give me a second, let me get my pencil. This area right here, there's basically one cartilage for these 3 ribs. They do attach to the sternum, but they don't have their own cartilage. Ribs 1 through 7 is 1, 2, 3, 4, 5, 6, and 7 have their own cartilage. That's why they're true ribs. The false ribs only have one connection. Ribs 8, 9, 10 have one connection to the sternum. And finally, there are 2 floating ribs. The floating ribs do not attach to the sternum. They only have an attachment to T11 and T12, thoracic vertebra 11 and thoracic vertebra 12. So again, true ribs 1 through 7 have independent connections to the sternum. The false ribs 8 through 10, well, 8, 9, and 10 share one connection to the sternum. And the floating ribs, ribs 11 and 12, have no connection to the sternum and are only connected to the thoracic vertebrae number 11 and 12. Okay, so that is what you're going to need to know about the ribs. Okay. Hey, right with this thing. Okay, so now we're going to start with the pectoral girdle. Basically, it's the shoulder. The shoulder girdle supports the arm. It's basically made up of 2 bones, the clavicle and the scapula. Now, the clavicle articulates with the sternum and articulates with the scapula, and it creates 2 joints. The joint at the sternum is known as the sternoclavicular joint, sternum and clavicle. The other joint is known as the acromioclavicular joint. This joint is between the clavicle and the acromioclavicular process, or the acromion. The third joint of the shoulder is where the scapula articulates with the humerus. And this joint is known as the glenohumeral joint. So you're going to need to know the 3 joints of the shoulder: sternoclavicular, acromioclavicular, and the glenohumeral joint. And again, the names are telling you what bones are articulating together. Glenohumeral is the glenoid fossa and the humerus. Acromioclavicular is the acromion and the clavicle. Sternoclavicular is the sternum and the clavicle. So let's talk about the clavicle. You're going to have to know what this bone is. Again, it's an S-shaped bone. And all I'm going to need you to know about the bone itself is its 2 sides: the sternal end and the acromial end. The sternal end is rounded and has a little indent in it where it articulates with the sternum. The acromial end is flattened out. Hi, Ashley, how are you?
Hi, sorry, I didn't want to say anything when
No, that's okay. I just saw you up there. Very cool. So again, the sternal end is circular, has a little indent in it. The acromial end is flat, and it's at this end of the clavicle that articulates with the acromion. Again, this is the most frequently fractured bone in the body. Again, to me, it's the Tony Romo bone, since he broke it many, many times, and I like Tony Romo when he's not playing football. Okay, so
Do we need right and left? I don't remember.
for the clavicle, no,
Okay.
no. The scapula, yes. We'll talk about that when we get in. The scapula, it's named because it looks like a spade. It's a triangular plate. It has 3 sides. It says it has 3 angles, but there's really only 2 angles that I'm going to need you to really know, and that's the superior and inferior angle, and we'll go over it. On the superior portion of the scapula, there is a suprascapular notch, and again, the word is telling you where it is. Supra means above. Suprascapular, above the scapula. And it's a notch. It looks like just a little area, a little hole that is a half a hole. The spine of the scapula, which is on the posterior side. The spine of the scapula splits the posterior side into 2 fossas, the supraspinous fossa and the infraspinous fossa. What's great about that is that in the supraspinous fossa, the supraspinatus muscle sits there, and in the infraspinous fossa, the infraspinatus muscle sits there. So the fossa is actually telling you what is in that area. On the anterior side of the scapula, we have the subscapular fossa. Again, the name is telling you what muscle is there, and that's subscapularis. They call the glenohumeral area a lateral angle. I don't think that's one that you have to understand, but you got to understand this side of the scapula. The acromion process is an extension of the spine of the scapula. And again, like I said, the acromion articulates with the clavicle, creating that acromioclavicular joint. On the anterior side, we have this finger-like structure coming off the scapula, and that's known as the coracoid process. And the coracoid process is really, really important because it's at the coracoid process where the short head of the biceps comes off of. And the pec minor has an insertion on that area. So, and I'm going to show you a picture in a second. We'll go through it. And finally, on the lateral side, we have a very shallow socket where the humeral head articulates, and that shallow socket is known as the glenoid cavity. The glenoid cavity. And the humeral head and the glenoid cavity form that third joint, the glenohumeral joint. So let's take a look at the scapula itself. So let's look at the anterior side. So we're going to look at this one first. So we'll start at the top. Remember, I said the suprascapular notch is on the top. Well, you can see the suprascapular notch here also. That's this space right here, right there. So here's the suprascapular notch right there. When we go medially, we have the superior border, which is the top half of the scapula. And then we have the medial border. The medial border borders the vertebral column. And this medial border of the scapula is a very important part and a very important area where a lot of muscles attach to it. The rhomboids attach to the medial border, and serratus anterior inserts onto the medial border. This bottom right here is the inferior angle. The inferior angle. Right here is the lateral border of the scapula. All right, the lateral border of the scapula. And again, many muscles come off of that area too, such as infraspinatus, teres minor, and teres major. This area right here is that glenoid cavity. It's the glenoid cavity that articulates with the humeral head. This bone sticking out right here is the acromion process. And the acromion, if you look on the right-hand side, here's the spine of the scapula right here. Well, the acromion is this area right here. So the acromion is an extension of the spine of the scapula. And the last bone on the scapula for the anterior side is this coracoid process. Kind of looks like a finger sticking out. This area right here is known as the subscapular fossa. Again, the subscapular fossa is on the anterior side, and this is where the subscapularis muscle sits. Let's look at the posterior view of the scapula. An important structure, like I said, is this spine of the scapula. Oh, let me just hear that. The spine of the scapula here, very important structure. If you see the spine of the scapula, you know that you're looking at the posterior portion. You're looking at the scapula from the back. The spine of the scapula splits the posterior portion into two parts. The supraspinatus fossa, the supraspinous fossa, and that's where the supraspinatus muscle is. And then below it is the infraspinous fossa, where the infraspinatus muscle is. We have other muscles that come off of this lateral border right here, teres minor and teres major, also. On the top of this glenoid fossa and on the bottom are two very, very important parts. We have the supraglenoid tubercle. Again, supra, above the glenoid. And the supraglenoid tubercle is where the long head of the biceps, that's the origin of the long head. On the bottom of the glenoid fossa is the infraglenoid tubercle, below the glenoid fossa. And it is here where the triceps muscle is the origin. So the biceps are on the top, long head of the biceps starts at the supraglenoid tubercle, and at the infraglenoid tubercle is the triceps. Very important. When you are thinking about your origins and insertions, those two muscles are muscles that we use an awful lot. So please know them. So again, the scapula has a great deal of landmarks that you guys really, really need to know. Okay, so when you're studying it, and I'm going to be sending this PowerPoint with this, with the video, so you'll be able to go through the PowerPoint too. You've got to know these landmarks. All right, you got to know them. They're going to be on the exam, and we use them an awful lot. As we go down the upper limb is divided into 4 areas. We're going to talk about those areas tomorrow. The 4 areas of the brachium. The brachium is basically the humerus from the shoulder to the elbow. The antebrachium is the forearm, basically from the elbow to the wrist. You have the wrist, which is known as the carpus, and the carpals are made up of 8 bones in 2 rows, which you will need to know. And finally, the hand itself, all you'll need to know is the metacarpals and the joints of the hand itself. So let's look at the humerus first. The humerus, the head of the humerus, this area right here, the head of the humerus articulates with the glenoid fossa, creating the shoulder joint. Okay? So the head of the humerus articulates with the glenoid fossa, creating the glenohumeral joint. On both sides of the humerus, there is a greater and lesser tubercle. These tubercles you need to know because it's at the greater tubercle that 3 of the rotator cuff muscles have an insertion. The supraspinatus, the infraspinatus, and the teres minor all insert into the greater tubercle. The lesser tubercle has the subscapularis, which is the 4th of the rotator cuff muscles. So you're going to need to know what the greater and lesser tubercle, where they are, and what muscles attach to them. In between these 2 tubercles is the intertubercular sulcus. You can call it the intertubercular groove. You can call it the biceps groove because the long head of the biceps goes through this groove. It's also an area where certain muscles attach to it. Pec major attaches in there. And very interestingly, latissimus dorsi, which is in your back, actually attaches into the bicipital groove there. On the lateral side of the humerus, we have the deltoid tuberosity, where the deltoid muscle attaches to. Again, very important area. So this is known as the proximal end of the humerus because it's closer to the body. This bottom half here is known as the distal end of the humerus because it's further away from the body. In the distal end, because it's at the distal end where basically the elbow is. So there's really important parts here. The first part is this bony area here. The bony area on the lateral side is known as the capitulum. The capitulum articulates with the radius bone, with the head of the radius. The next bone right next to it is known as the trochlea. And the trochlea articulates with the ulna bone, the 2 bones of the forearm. So again, the capitulum articulates with the radius. The trochlea articulates with the ulna. Above each of these areas are fossas. These fossas allow for the radius and the ulna to have space to move. The one above the capitulum is the radial fossa. The one above the trochlea is the coronoid fossa because It's the coronoid process on the ulna that articulates with that. We'll get to that in a second. So you need to understand the distal end. On both sides of these bones, there are what we call epicondyles. On this side, it's a lateral epicondyle. On the medial side, it's a medial epicondyle. If you feel on yourself on the thumb side at the elbow, you'll feel the lateral epicondyle right there. And you will feel on the inside by the elbow, the medial epicondyle. These are very, very important areas. The medial epicondyle is actually the origin point for many of the wrist and for the wrist and finger flexors, where the lateral epicondyle is the area where the extensors come off of, the majority of them. So you need to know the medial and lateral epicondyles of the humerus. Remember, they're on the humerus. On the sides, right here, on this side and on this side, there are ridges, all right? So you'll see right here a lateral supracondylar ridge and a medial supracondylar ridge. The lateral supracondylar ridge is really important because it's where the brachioradialis muscle is its origin. Okay, that's the origin of that muscle, is the lateral supracondylar ridge. And again, the name is telling you where it is. Lateral means it's on the outside. Supracondylar, above the condyle. Remember, so if you take a look, here's the lateral epicondyle. Here's the lateral supracondylar ridge. It's above the lateral epicondyle. So again, the name is telling you where it is. The last structure that you're going to need to know is on the posterior portion of the humerus. And it's this circled area right here that I'm arrowing down. And this is known as the olecranon fossa. All right, that's where the olecranon portion of the ulnar bone goes in there when we flex and we extend our elbow. All right, if you put your elbow on the ground, on the table, you're actually putting the olecranon process of the ulna on the table itself. So again, you're going to need to know this fossa also. All right, and this fossa, there's only one fossa on the posterior side, where on the anterior side, there's two. All right, the radial and the coronoid fossas. Okay. Next bone is the radius bone. The radius bone, you will know the radius, like I said yesterday, from the head of the radius. This bone has a rounded head. This is the head of the radius. On the top of that head, there is an indent. All right, that allows for movement. All right, when it attaches, when it articulates with the capitulum. Remember, the capitulum on the humerus articulates with the radius, and specifically the head of the radius. So for the radius bone, you need to know the head of the radius. On the side here, on the medial side, there's a tuberosity or a bony area that stands out. And that bony area is known as the radial tuberosity. It's at the radial tuberosity where the biceps brachii inserts into. So I've already told you actually where the origins and insertion of the biceps brachii. The long head is the supraglenoid tubercle. The short head is the coracoid process, and it inserts onto the radial tuberosity. This is the way you're going to have to explain it to us. Okay? So again, for the radius, the radial head you'll need to understand, the radial tuberosity, and on the bottom, on the distal side, there's a radial styloid process. If you get confused with the radius and the ulna on which bone is which, the bone on the thumb side, the bone on the thumb side is the radius. The bone on the pinky side is the ulna. Now I'm talking about the forearm again. So again, the forearm bone that's on the thumb side is the radius. The forearm bone that is on the pinky side is the ulna. Okay, so that's what you're going to need to know about the radius. The ulna bone, again, this is the second of the forearm bones. You need to know, yeah, that was good. Of course it goes when I don't want it to go. The ulna bone is very distinctive. This area right here makes the ulna bone very distinctive. It's that hook area. The hook area is known as the trochlear notch. It's the trochlear notch that articulates with the trochlea on the humerus. Now, basically, there's three parts to this proximal end of the ulna. The top part is the olecranon. That's the bony point of the elbow. In the middle is the notch itself, is the trochlear notch. And then on the bottom here, right here, this point is known as the coronoid process. Remember, on the anterior portion of the humerus, there was a coronoid fossa. This coronoid process articulates with that coronoid fossa. So the ulna bone is very distinctive. It has that teeth-looking end. The proximal end looks like teeth. It looks like a mouth. It's that trochlear notch. And remember, the olecranon is on the top, the trochlear notch itself, and the coronoid process. And at the end of the ulna, just like the radius, there is a styloid process also there too. Now you'll notice in between these bones is what's called a membrane, the interosseous membrane. It has a couple of jobs, and we'll talk about those when we get to kinesiology. But it connects the two bones, and it allows for forces to be transferred. Now, let me also say this. If you were to hold your hand out in front of you with your palms up, and if you did palm up and palm down, palm up and palm down, it is the radius bone that moves. The ulnar bone does not. Whenever we pronate our pronate our forearms, it is the radius bone that does the job. The radius crosses the ulna. It is only the radius bone that moves. Okay, so this way you'll know for the future. The radius bone is the bone that moves.
So what tears if it goes the other way?
I'm sorry?
So what tears or breaks if it goes the other way? 'Cause it
Nothing
doesn't-
tears. What happens is it goes like an X. So if you have your arm out in front of you, the radius and the ulna are parallel to each other with your hand pointing upwards. When you pronate your hand and move it downwards, the radius crosses over the ulna. And then when you return, the radius crosses back. So with your palm up, the radius and the ulna look like train tracks. They're parallel to each other. When you do palms down, it looks like an X.
I feel that.
Where the radius crosses over, and when you go palms up, the radius comes back to its original position. Okay?
Yeah.
Beautiful. All right. The carpal bones. So now we're talking about the wrist. What you're going to need to know, just like I said yesterday, is you're going to need to know the rows. The proximal row is the row closest to the body. The distal row is the row closest to the fingertips. And again, go from the thumb side. The proximal row bones are scaphoid, lunate, triquetrum, and pisiform. In this picture, it is the tan bones. The bones that are tan are the proximal row of bones. The bones in green are the distal row of bones. Those are made up of the trapezium, the trapezoid, the capitate, and the hamate. That's what you need to know. That is what you need to know with that. Now, when we're talking about the joints of the hand, there are a few of them. So the joint right here between the carpals and the metacarpals is the carpal metacarpal joint. The carpal metacarpal joint, also known as the CMC joint. The carpals and the metacarpals. Here's the metacarpals right here. These long bones are the metacarpals. Then there's a joint between the metacarpals and the first phalange. Right? This is known as the metacarpal phalangeal joint, or the MCP joint. And remember, I said that the MCP joint makes up the knuckles, is the knuckles. The third joint you need to know is the joint between the first set of phalanges, between digits 2, 3, 4, and 5. This is known as the proximal interphalangeal joint, or the PIP. All right. So if you were to take your finger and just bend part of it, if you can see what I'm doing here, you are bending at the proximal interphalangeal joint. If I take my hand and do this, I'm bending at the metacarpal phalangeal joint. The last joint that you need to know is the ones here at the end. This is known as the distal interphalangeal joint. Again, the name is telling you This is the distal portion, and it's between the phalanges. If you can see on the camera, the distal interphalangeal joint, if I was to flex it, would look like this. This very small motion at the end of my finger. So this is the DIP. This is the PIP. And this is the MCP, where I flex my whole finger. That's what you need to know about the carpals and the metacarpals and the joints themselves. Let me clear that. That. Come on, baby. Okay, so the carpal bones, come on. All right, the metacarpals and the phalanges we talked about just now. All right, up to the legs now. We're up to the lower extremity. All right, so here's a picture of the pelvic girdle. So as you can see here, here's the two hip bones that we spoke about yesterday. Here's number one, here's number two. And in between is the sacrum. So this is the sacroiliac joint right over here. We'll split up the pelvis bone in a second, but this is what the pelvic girdle looks like. All right, this is what the pelvic girdle looks like. Let me add here. I had it figured out. Oh, I do. All right, so the hip bone, we spoke about it yesterday. There are a bunch of landmarks that you need to know. Okay, so let's go through them. On the ilium, the first landmark that you need to know is the iliac crest. Now, the iliac crest is the superior portion of the bone. I'm coloring it over right there. This is the iliac crest right here on the top. Right here is the acetabulum. That's where the femur attaches to. I'm not going to ask a question about this obturator foramen, but this hole right here is known as the obturator foramen. It is through that hole that basically the sciatic nerve passes through. So iliac crest, the acetabulum, and the obturator foramen. Those are the first real visible landmarks. Now, we have some other very important landmarks that you need to know. So, first things first, I know that this is the posterior side because right here is the ischial tuberosity, and that's what I sit on, which means this right here is going to be the anterior side. And that's important to know because there are a lot of landmarks on this hip bone that you need to know. The first one is this area right here. This is known as the anterior superior iliac spine. All you have to do is call it the ASIS. All right? So at the end of the iliac crest, on the anterior side, is the anterior superior iliac spine. The next landmark below it is the anterior inferior iliac spine. The anterior superior and the anterior inferior. When you guys get a hold of the bones, it'll be much more visible. Okay, much more visible. The next one on the ilium is this area here on the posterior section. This circular section is known as the greater sciatic notch. the greater sciatic notch. Now, let me also point out that there are iliac spines on the posterior side too. Right here is the PSIS, the posterior superior iliac spine, and right below it, right before the greater sciatic notch, is the posterior inferior iliac spine. All right, so we have ASIS, we have AIIS, we have PSIS, and we have PIIS. And again, right under the PIIS is the greater sciatic notch. And we have SOS. Yes, that is true. On the ischium, the important part of the ischium that you're going to need to know is, of course, the ischial tuberosity. That's that rough area here on the posterior side. There's also a small notch right here. This is the lesser sciatic notch. All right. So the two sciatic notches are on the posterior side. And the notch themselves, it's the size. You got the greater sciatic notch and you got the lesser sciatic notch. On the pubis, I really have no landmarks that you really need to know. So again, on the hip bone, you need to know the iliac crest. That's the top of the bone. You need to know the acetabulum, an incredibly important part. That's where the head of the femur articulates with. You're going to need to know the ASIS and the AIIS, these two areas here. You're going to need to know the PSIS and the PIIS on the posterior side. You're going to need to know the greater and lesser sciatic notch. And you're going to need to know the ischial tuberosity. Again, the ischial tuberosity is your guide. You sit on your ischial tuberosity. Your ischial tuberosity is posterior, which means the other side is going to be anterior. All right, that's an important landmark for you guys to understand. All right, and it will be very visible when you guys have the bone in your hand. It's a rough area. It's a thick bone. Think about it. If we had a thin bone that we were sitting on, we would break it all the time. So that ischial tuberosity has to be thick, has to be strong. Very important bone. All right, the femur. Femur is the longest and strongest bone in the body. The femur has the head of the femur. The head of the femur articulates with the acetabulum of the hip bone. Here is the head of the femur. Within the head of the femur, there is a small hole. Within this hole, which is known as the fovea capitis, there is a ligament that helps attach it to the acetabulum. What it also does, it allows for nutrition to be given to the acetabulum. So within the femoral head, there is a fovea that has a ligament, helps with the attachment, helps with nutrition. The next part of the femur that you need to know is the greater and lesser trochanter. These two areas here, these two areas are for muscle attachments. We also use the greater trochanter to actually measure assisted devices. We use that landmark to help us and guide us to set up an assisted device correctly for a patient. So again, the greater and lesser trochanter. Remember, on the humerus, we had the greater and lesser tubercle. Same idea. That's an area for muscle attachment. In between, there is a line. It's known as the intertrochanteric line, a line between the trochanters. This part of the bone right here, this bone is the posterior portion of the bone. On the posterior portion of the bone, there is this ridge that goes down right here in the middle. This ridge is known as the linea aspera. All right. Again, the linea aspera is on the posterior portion of the femur. And on the linea aspera, this is an attachment point for muscles. An attachment point for muscles. On the distal end of the femur, so this is the distal end of the femur right here. Again, this is the proximal end of the femur up here. This is proximal, and this is distal right down here. At the distal end of the femur, we have condyles. This right here is a medial condyle, and this one right here is a lateral condyle. These condyles articulate with the tibia and allow us to flex and extend our knee. So we have femoral condyles, and right above the femoral condyles are medial and lateral epicondyles. Again, above the condyles. All right. And that is also an attachment point, but those are actually attachment points for ligaments, for the lateral collateral and medial collateral ligament that actually hold the femur and the tibia together. So we have medial and lateral condyles, which articulate with the tibia, and we have medial and lateral epicondyles, which are above the condyles. Between the condyles, we have an intercondylar fossa. We have basically a whole area. And it's that whole area that actually helps the patella to move. All right? So the important aspects of the femur, the femoral head, the fovea within the femoral head, the greater and lesser trochanter, and the intertrochanteric line. On the posterior portion, we have the linea aspera, which is a ridge. On the distal end of the femur, we have two condyles, a medial and lateral condyle, and above them, we have a medial and lateral epicondyle. Between the condyles, we have an intercondylar fossa. Those are the important aspects of the femur itself. The patella, that small bone, also known as the kneecap. But when you describe it to me or Mr. Ingerman, you'll be calling it the patella. Now, the patella is between the femur and the tibia. It is in this position right here. All right? Well, I need you to know the patella, and I need you to know the two parts. The top part right here, which is the broader part. All right? This is known as the base. All right? The top part is known as the base. Yes, I know it is confusing. I have no argument with you. I didn't make it up. Okay? The base is on the top. It is the broad superior portion. The bottom part of the patella is known as the apex. The apex is pointed and is inferior. So the base is superior, the apex is inferior. That's what you need to know. That is what I need you to know. Also know that it is a sesamoid bone because it is within the quadriceps tendon. It is within the patella tendon itself. But on the exam, I will ask you about the base and the apex of the patella. All right. It is confusing. Again, I have no argument with you, but all the information is here for you. The base, broad and superior. It's larger. The apex is pointed. All right. It looks like an arrow. All right. And that's the inferior portion of the patella. The tibia is that thick bone. This is a thick weight-bearing bone. All right. I'm doing good. Okay. The tibia is this bone right here, the big, thick one. Right there. All right. On the proximal end, we have a medial and lateral condyles. Those medial and lateral condyles of the tibia articulate with the medial and lateral condyles of the femur. It allows for us to bend and extend our knees. In between the two condyles, there is an intercondylar eminence. It kind of looks like a mountain ridge. And that mountain ridge separates the condyles of the tibia. Okay, so we got medial and lateral condyles of the tibia. We have an intercondylar ridge. On the anterior portion of the tibia, there is a bony projection. It is known as the tibial tuberosity. The tibial tuberosity is where the patella tendon from the quadriceps attaches there. And again, allows us to kick the leg outwards. Okay? So the tibial tuberosity. Now, there is an area here that I want you to know. On the anterior medial side, there is an area known as the pes anserine. A-N. Pes anserine. Just keep this in your mind, all right? I'm not going to put it on your test until kinesiology, but it's on the anterior medial side of the tibia. And there are three important muscles that attach to the pes anserine. We got the gracilis muscle, the sartorius muscle, and the semitendinosus of the hamstrings. All three of those muscles insert into the pes anserine. So just keep in the back of your mind, there's this attachment point that is really, really important on the tibia. Finally, at the distal end, right down here, is the medial malleolus. The tibia makes up the medial malleolus. Again, the medial malleolus is the distal end of the tibia. Very important. So on the tibia, what you need to know are the two condyles, the medial and lateral condyle. Those are on the proximal end of the tibia. In between those condyles is the intercondylar eminence. a mountain-like structure, and that's actually where the anterior and posterior cruciate ligaments attach to. On the anterior side of the tibia, we have the tibial tuberosity. That is where the quadriceps tendon attaches. The pes anserine is on the anterior medial side, and 3 important muscles attached to it. And finally, the medial malleolus, which is the distal end of the tibia. All right, and that makes up the medial malleolus, is the distal end of the tibia. The fibula is that small, slender bone. The fibula is the lateral bone. Tibia is medial, fibula is lateral. Basically, it has no weight-bearing function. This bone can break quite easily. It has 2 ends. It has a proximal end and the distal end. And it's the distal end of the fibula makes up the lateral malleolus. The distal end of the fibula is the lateral malleolus. So the medial malleolus is the tibia, the lateral malleolus is the fibula. That's what you need to know. The ankle. What you need to know about the ankle, the first thing is the talus. Oops, sorry. Come on. So the talus is this pulley-like structure up here. All right. Let me get out of this. I got the wrong bone there. Okay. So the talus is this round circular, looks like a pulley there. It's the most superior tarsal bone. And it's the talus that articulates with the medial and lateral malleolus and allows our foot to dorsiflex and plantar flex. At the bottom of our foot is that thick bone, and it's the largest bone. And that's this bone right here. I guess this is a better picture. Where's my pen? On pen. When I don't want it to move, it moves. And when I want it to move, it doesn't move. All right. There's my pen. Okay. So on the back right here is the calcaneus bone. The calcaneus forms the heel. And it's on the calcaneus that the Achilles tendon that comes from the gastrocnemius muscle and the soleus muscle attached there. And so the talus and the calcaneus, and I'm going to show hopefully a better picture of that next. Of course, when I want it to move, it doesn't move. All right. So this is the medial look of the foot. This is from the medial side. All right, where's my pencil? Come on, pencil. Nope, of course not. Guess I can't use a pencil or pen here. All right. On the top, you will see the talus. Kind of looks like a pulley. On the bottom is the calcaneus, that big, thick bone. Between the talus and the calcaneus, there is a small bone. The bone is known as sustentaculum tali. It basically is a shelf, and it helps protect the talus. The next bone after the talus is the navicular bone. The navicular bone is a bone that you can actually palpate and that you can feel. You'll be able to feel the navicular tuberosity on that bone. Right above the navicular is the medial cuneiform. We have 3 cuneiform bones. We have a medial, an intermediate, and a lateral. And then on the other side, on the lateral side, we have a cuboid. And finally, after the cuneiforms, we have the metatarsals. The metatarsals are those long bones. All righty. Believe it or not, that is everything. Let me get out of this. All right. Get out of the share. Okay. Okay. So what I'm going to do is I will stop the recording. I will set everything up. When I send the recording out, I'll also send the PowerPoint of the bones, this whole PowerPoint that I went over. All right. Do you guys have any questions? I know a lot of information.
Will the tests on this be together with the muscle tests, or will it be 2 separate tests?
The final definitely will be cumulative. I'm going to try to separate it as much as I can. The first, understand this, I'm not doing big exams, I'm doing small quizzes. So what we'll be doing the first week will most likely will be bones and the bony landmarks. And then weeks 2 and 3 will mostly be muscles. But understand this, here's the thing. With the muscles, you're going to have to know the origins and insertions, and it's bones. So you're going to have to know them anyway. So I'm going to be splitting it up as much as I possibly can. But when we're talking about origin and insertions, it's all bone. All right, those muscles, the muscles move bones. So that's the way it is. But the first week it'll be bones and directional movements and terminology, which we'll be doing tomorrow.
All right.
Okay.
Sounds good.
Okay. Anything else, guys?
All good.
All right. Like I said, I will send this out. I gotta upload it first. It takes about 50 minutes to do. So I'll upload it. I'll probably just gonna go home and send it to you guys. And tomorrow, 1 to 3 tomorrow. All right. Tomorrow is Wednesday and the last day before holiday week. So we'll be going from 1 to 3 tomorrow. So if you can make it, great. If not, I will send the videos out to you guys. Okay.
All right. Thank you.
All right, guys. Have a nice afternoon. See you tomorrow.